Most people assume that when a surgeon recommends an operation, it must be the correct path forward. The logic feels solid. The doctor has the training. The hospital has the tools. The consent form is placed in front of you, and all that remains is a signature. For years, I believed in that same chain of trust without hesitation, until I began to notice patterns that were impossible to ignore. I started counting, not just successful procedures, not just textbook recoveries, but the patients who walked into the hospital one way and left fundamentally altered. Not improved, altered. A man who entered with manageable back pain and left unable to walk independently. A woman who survived open-heart surgery but spent 6 months battling complications that were never part of the initial conversation. These weren't rare, isolated cases, and they were frequent enough to demand a deeper, more honest discussion. What I am about to share is not meant to create fear, but to provide clarity. Because the truth is this: for patients over 60, especially those with underlying health conditions or frailty, surgery carries risks that are often undercommunicated, underestimated, or misunderstood. Let's begin with a simple analogy. If you take a brand new car and a vehicle with 200,000 miles on it and subject both to the same stress test, you do not expect identical results. And yet, for decades, medicine approached older patients using protocols developed for much younger bodies. The same anesthesia, the same recovery expectations, the same timelines. That approach is changing, but not quickly enough. When an older adult undergoes general anesthesia, multiple systems in the body respond differently compared to a younger patient. Cardiovascular demand increases, while cardiac reserve may already be reduced. Pulmonary function declines, meaning anesthetic gases take longer to clear. Renal function slows, impairing the body's ability to process medications and maintain fluid balance. And then there is the brain. One of the most under-discussed complications in older surgical patients is something called post-operative cognitive dysfunction. Research published in journals such as the New England Journal of Medicine and Anesthesiology has demonstrated that cognitive decline after surgery, ranging from mild confusion to prolonged memory impairment, can persist for weeks or even months. In patients over 70, the incidence is significantly higher than many clinicians openly acknowledge. And this does not mean age alone should prevent surgery. I have operated on patients in their 80s who recovered faster than individuals in their 50s. The critical variable is not age, it is frailty. Frailty is a clinical syndrome defined by reduced physiological reserve and increased vulnerability to stressors. Studies, including those from the Journal of the American Geriatric Society, estimate that approximately 40% of individuals over 75 exhibit signs of frailty, rising to nearly 60% in those over 85. Frailty predicts surgical outcomes far more accurately than chronological age. This leads us to the central question: not can the patient survive the operation, but can the patient survive the recovery? Those are not the same question. Now let us examine 5 categories of surgery where this distinction becomes critically important. When the first is open heart surgery in frail patients. Coronary artery bypass grafting, commonly referred to as CABG, is one of the most frequently performed major surgeries worldwide. It has saved countless lives. For appropriately selected patients, it remains a powerful and effective intervention. However, the procedure requires stopping the heart and placing the patient on cardiopulmonary bypass, a machine that temporarily replaces the function of the heart and lungs. While this technology is remarkable, it introduces systemic stress that affects every organ simultaneously. In frail elderly patients, studies from sources such as the Society of Thoracic Surgeons database in circulation have shown complication rates ranging from 30% to 40%. These include stroke, acute kidney injury, prolonged mechanical ventilation, and delirium. Mortality rates in high-risk elderly populations can reach 10 to 15% within 30 days post-operation. Alternative approaches now exist. Transcatheter aortic valve replacement, or TAVR, allows valve replacement without opening the chest or stopping the heart. Clinical trials, including partner studies published in The Lancet and NEJM, have demonstrated comparable outcomes in selected populations, with significantly reduced recovery times. The key is not rejecting surgery, but asking whether a less invasive option is appropriate. The second category is aggressive spinal surgery. Chronic back pain is nearly universal among older adults. Surgical interventions, such as spinal fusion, are increasingly offered as solutions, yet evidence raises serious concerns. A large study published in Spine reported complication rates exceeding 40% in patients over 65 undergoing complex fusion procedures. Complications include infection, thromboembolism, hardware failure, and adjacent segment degeneration. Equally important, multiple randomized trials and systematic reviews, including those in the BMJ and JAMA, have shown that for many patients with degenerative spine disease, long-term outcomes of surgery are not significantly better than non-surgical management, including physical therapy and targeted injections. The third category involves major cancer resections. Cancer diagnosis often triggers an understandable urgency to remove the tumor. However, the objective of treatment must always be carefully defined. Extending life, improving quality of life, or both. Procedures such as the Whipple operation for pancreatic cancer are among the most complex in medicine. While potentially curative in select patients, they carry substantial risk. Data from the American College of Surgeons National Surgical Quality Improvement Program indicates high rates of complications, particularly in elderly patients with comorbidities. The concept of failure to rescue, widely discussed in surgical literature, refers to the inability to prevent death after a complication occurs. Studies show that elderly patients are significantly more likely to experience this outcome due to reduced physiological reserve. In some cases, non-surgical options, chemotherapy, radiation, targeted therapies, or even palliative care, may offer comparable survival with better quality of life. And the fourth category is elective joint replacement in medically complex patients. Hip and knee replacements are highly successful procedures in appropriate candidates. They can dramatically improve mobility and quality of life. However, in patients over 75 with multiple comorbid conditions, risks increase substantially. Complications include deep vein thrombosis, pulmonary embolism, surgical site infection, and postoperative pneumonia. Research published in the Journal of Bone and Joint Surgery highlights the importance of preoperative optimization. This brings us to an essential concept: prehabilitation. Structured programs focusing on improving physical fitness, nutrition, and medical stability before surgery have been shown to reduce complication rates and improve outcomes. Yet many patients are never informed that such preparation is possible or necessary. The fifth category is emergency abdominal surgery. Unlike elective procedures, these situations allow no time for preparation. Conditions such as bowel perforation or internal bleeding require immediate intervention. Mortality rates in elderly patients undergoing emergency abdominal surgery can reach 30 to 50%, as reported in Annals of Surgery and World Journal of Emergency Surgery. The combination of acute illness and reduced physiological reserve creates a perfect storm of risk. This underscores the importance of early symptom recognition and advanced care planning. Discussing treatment preferences with family members before a crisis occurs can profoundly influence decision-making during emergencies. So what should patients do with this information? There are four essential questions every individual over 60 should ask before consenting to major surgery. First, what happens if I do nothing? Understanding the natural progression of the condition provides critical context. Second, is there a less invasive alternative? Advances in medicine have expanded options significantly. Third, what does recovery look like for someone with my specific health profile? Personalized information is far more valuable than averages. Fourth, what are your outcomes for patients like me? Surgeons track these data, and transparency matters. It is also important to recognize the growing role of non-surgical management. Optimized medical therapy, rehabilitation, and lifestyle interventions can effectively manage many conditions once treated exclusively with surgery. I want to leave you with a perspective that has guided my practice for years. A surgical recommendation is not a command. It is the beginning of a conversation. You are not passive in this process. You are a decision maker. The surgeon brings expertise. You bring values, priorities, and lived experience. The best outcomes occur when those elements align through open, honest dialogue. Surgery remains one of the most powerful tools in medicine. It saves lives every day. But power must be used thoughtfully, especially in vulnerable populations. If there is one message to take from this, it is this: informed patients make better decisions. Ask questions, seek second opinions, take the time you need. Because in the end, the goal is not just survival, it is a life worth living. And that is a goal every medical decision should serve.